Hello, and welcome to Navigating Xylazine Wound Care Strategies for Understanding, Prevention, and Healing. Here in a few moments, we'll be joined by our expert presenter, Jason Bienert, who will be talking about xylazine wound care and providing examples for you throughout today's presentation. If you have questions for our first presenter, Jason, you can submit them at any time using the chat or Q&A function in your Zoom player. We'll try to allow for as much time as possible for all the questions that come in today. After we've heard from Jason, we'll be joined by Zach Hansen, will talk about the local implications of xylazine on the West Virginia and specifically Huntington community, and how we can find more resources to help with this process. During today's presentation, you'll hear about Healthy Connections, which is the producer of this webinar today. Healthy Connections is a Marshall Health initiative and is a coalition that supports pregnant and parenting families struggling with substance use disorder. By working together, we're able to address the high rate of neonatal abstinence syndrome in our region and the resulting impact on child development and family stability. By integrating existing programs and services and fostering collaboration, Healthy Connections enhances interagency efficiency through research, education, and collaboration to make a meaningful difference in our community. You can learn more at healthyconnectionswv.org or marshallhealth.org/healthyconnections. Today's presentation is also being co-produced by the Training Center. That's the West Virginia Behavioral Workforce and Health Equity Training Center at Marshall University, which aims to support, develop, and expand the behavioral health workforce in West Virginia by increasing access to high-quality, evidence-based trainings at no cost to attendees. The Training Center is funded by the West Virginia Department of Human Services Bureau for Behavioral Health and the Substance Abuse and Mental Health Services Administration. Additional training sponsored by the Training Center are available at wvbhtrainings.org. In addition to these organizations, Quality Insights is helping to produce today's webinar. Quality Insights has been using quality improvement science, workforce development, education, and collaboration to develop and bring best practices to healthcare settings and communities for more than 50 years. Quality Insights is pleased to be partnering with the Training Center and Healthy Connections to bring you today's expert presentation. With that, I'd like to introduce our keynote speaker, Jason Bienert. He is a wound care nurse working in Maryland, providing empathetic and compassionate low barrier health care to people who use drugs. He's treated hundreds of wounds related to xylazine over the last 4 years. Pulling together 10 plus years of critical care, emergency, and advanced hospital based wound care, Jason led the successful development and implementation of a novel wound care program within a peer-led nonprofit harm reduction organization in rural Maryland. He's employed by Johns Hopkins Bloomberg School of Public Health as a senior research nurse working on multiple xylazine projects. With that, Jason, I'm going to see if we can pass remote control to you to advance your slides. If for some reason that doesn't function, just let us know and we can advance them for you. Jason, thank you so much for your time and expertise. It appears you may still be on mute from what I'm seeing. Oh, you were unmuted for 1 second. There we go.
There we go.
Awesome.
Let me check to see if I have access to moving it forward. And it doesn't quite seem like I do.
Oh, there you go.
Oh, that was me? Okay. Very good.
That's all you.
Okay, sorry, I had a little bit of issues with my hotspot logging on. I know I just hopped on. So my name's Jason Bienert. The reality is I'm just a nurse taking care of people that had wounds that I didn't know anything about. And that's how I ended up sitting here talking to everyone that's logged on for this. Um, Today we're going to cover a little bit of basically my process in how I came to be, and through that, hopefully I can share everything I've learned, and we'll just jump right in both feet. It's not moving now. Okay, so I just want to. This is one of the biggest questions that's ever come up. I use people's pictures with their faces. Everyone that's ever been photographed that I use has given full consent to continue the process forward and sharing this information with everybody. It's really important for me to pass their story forward, so that's why this is more of a storytelling event more than just me reading stuff to you. Everybody's, like I said, everyone's given their consent, and the reality is two people have definitely passed away. One person is missing, and we presume that she has passed away also. And then there's someone that's a triple amputee that when these photographs were taken, he had all of his limbs. And this is all from Xylazine complications. So I think this is really important to share this forward. Next. Maybe that was me. I always put a quote in my presentations. I think this is a lot to read. The slides will be available later, but I reread Catcher in the Rye not that long ago, and this really stood out to me that, you know, I'm just lucky enough to have kept records for stuff, and this isn't really about education, it's history. I'm sharing their history. Again, I'm just passing on the song that these folks have sung, and some have stopped singing. So hopefully someone can gain something and maybe stop that in the future. What we're going to cover, Xylazine 101, some basics if people don't already know, and then we're going to get into what I know, and it's the complications. It's overdose, because I wouldn't be a good nurse if I didn't talk about that, wounds, and treatment considerations. And what that means is treatment might be different than some people assume. Treatment also consists of, getting into treatment itself, like detox, long-term, like recovery kind of stuff. And then I'm also going to dabble a little bit into what we're doing and how we did it, but that's throughout this whole presentation. Next. And this is something that I just jump in the shallow end with folks that I'm not familiar with. I've been to West Virginia a couple times talking about Xylazine, and I found this to be helpful. Like, I'm a nurse, I did drugs, I currently do not. The future's unclear. I don't know what tomorrow will bring, but right now I don't. I'm an ally to everyone in recovery. I actually openly, publicly support safe drug supply, like a prescription for heroin wouldn't need me anymore. I publicly support anyone that's using drugs. It's their right to do what they feel they want to do. All pathways of recovery. I worked at an abstinence-based only kind of joint in the very beginning to completely managed use. That I've met many people that can use substances safely, but not everyone can. And I believe that drug users have rights. And the one that I always pass on, like, kindness is free. Everybody always asks about how you get programs developed and the funding for it. And a lot of what I've done just comes out of basic kindness. Next, please. Warning shot. There are pictures of Xylazine wounds. This is early in the morning. Hopefully it's not too close to lunch. Next. So a fun fact. Next, please. 100% of people who suffer from opioid use disorder are human. This means so much. I came from the hospital world. I was an ICU nurse. I worked at a wound center. I ran a wound center. I then stepped away and worked cardiac cath lab, fixing people's heart attacks when they come in emergently. And the one thing that we detach from in medicine completely is that we're treating a human. Keep that in mind through the rest of these photos. And these are the guys that contributed to how I know what I know now. Next. This is me providing wound care in rural Maryland. For 4 years, I worked at that nonprofit that had a lot of adjectives describing it. It was a recovery community organization. I was the only person that wasn't in recovery. Everybody was abstinence-based. But there was a deficit in this community. It's rural Maryland. It sits below Delaware and Pennsylvania. It's the mouth of the Chesapeake Bay. So it has watermen there, it has rural farming, and it has a deficit. It has one hospital that's community based that suffered a lot. It's 45 minutes from Philadelphia, so you can hit Kensington right away. Um, this area, the reason why I feel like I'm equipped to discuss West Virginia drug problems is because Cecil County, Maryland is just like West Virginia. Pill mill doctors that were part of the problem, easy supply of heroin, then fentanyl, then pills, then fentanyl, and then fentanyl was xylazine. So this is the lady lived in a building the size of her shed that's in front of us to the left. And then next, please. So the woman I was taking care of is on the right. That's her arm. That's one of the worst wounds that there's bad pictures, but that's kind of one of the worst wounds. The woman on the left is missing. That's the woman that may have passed away. There's rumors that she did overdose. I have not got that confirmed, but she had a foot to ankle or ankle to knee wound, and we were wrapping it. Next, please. Girl on the left is gone, overdose. These photos were used with permission from the Wall Street Journal. They traveled around with me twice, and I thought I've never had a photographer capture the humans I was taking care of in the way I see them. The girl on the left is like the most ornery cherub from hell I've ever met. She'd smile at you, but I would never trust her with anything of mine of value. Sweetheart. And the guy on the left is now a triple amputee. He has his right hand only left on his body. Next, please. So this is where I started. They requested my time to come up as a volunteer. They got in touch with me from a health department employee that knew that I worked with people that use drugs, and I treat them like humans, and that's how he and I became friends. And then I went up and I said, you definitely have a wound problem I've never seen before. This is probably 2019, 2020, right when COVID was happening, starting to bubble up. And they said, well, come up for a day, and the day I was busy. Then they're like, well, maybe we can hire you. So they paid me for 1 day a week, and then they were like, we need you, and I started working with them. And in the beginning, it was so slow. It was just me, and I hate the term meet them where they are with the harm reduction stuff, but really we needed to meet people where they were. The place bought me a camper. It was useless. Nobody in rural Maryland wants a 39-foot camper that says "We Do Recover" on the side of it, sitting in the front lawn as I'm doing wound care on them. And we were kind of stuck. So people could either get to us, and we were along a busy highway, and we did have foot traffic, or they had to get a ride, or we could provide a ride, but it still required people to show up where I was. So we kind of changed it. I asked for a peer. I asked for a certified peer. And I really wanted someone that was personable, someone that would keep me safe and wasn't a wild child. And I wanted someone with lived experience in the community. Next, please. So this is in my head. This is I talked to my wife, and this is what I came up with. I want Joan of Arc. I want someone that's riding a steed that's armored. She's valiantly fighting in battle with slain people all over. This is what I want. Next. And this is what I got. Unfortunately, what I wanted and what I got were worlds apart, but I got what I needed. This young lady had 2 years of active recovery in NA. She never lost her knack for speaking to people on the street. She was a sex worker. She was also, at this point, had fought and got regained custody of her 2 little boys. So she was the trooper. She was better than any Joan of Arc. And she also knows I'm using this photo. She's embarrassed that this is going around now. Next, please. So this is where I'm like, there's something causing these wounds. And what I came to find out through some roguish actions of a health department employee in one of the other counties that sent a sample in through Maryland State Police, their drug lab. They had a family member that was a state trooper, and they sent it in for them. And we heard the word xylazine. So this is my rabbit hole for xylazine. Xylazine is a strong synthetic alpha-2 adrenergic agonist. Lots of words. What it means is it was originally developed as a blood pressure medicine, and all those words basically describe the drug's ability to alter the smooth muscle inside your arteries and make it loose and tight. And by doing that, it increases your blood pressure. It works better in arteries than in veins, but that's basically what the term means. Um, Interestingly, though, like all drugs, it has cousins. When they developed this, one of the biggest cousins was clonidine. Bayer Pharmaceuticals developed xylazine to be a clonidine-like drug. Clonidine is a really bad blood pressure medicine, but it's great for withdrawal cravings, to help stave them off. Interestingly, though, it's also related to phenothiazines and tricyclic antidepressants, and these play in later on in this conversation. Phenothiazines are antipsychotics, and they're old generational stuff. This is stuff you might see in the 70s and the 60s used in the quote-unquote nut huts, like where they would lock people up for manic episodes and give them drugs and stuff like that. That's where phenothiazines. Tricyclic antidepressants have been around for a while. They know they have some pain relieving properties. They also know that they're not the best antidepressants, but that's kind of where they fit into this. And dexmedetomidine. Dexmedetomidine is a prescription drug that is used only in the ICU. It is a sedative, much like its cousin xylazine. It has some of the same properties of sedation, and in animal care they also use it. Recently, we've been finding medetomidine in some of the projects I'm part of in Maryland. They think it might be one-offs. Like someone saying, "Oh, it's a sedative from animal care," and someone that works at an animal hospital just stealing what they think it might be. Medetomidine may be the next drug in our drug supply too. And I debated putting this on there. There's a link to this at the end. I'm not going to get into it, but recently they discovered that xylazine is a synthetic opioid that binds fully to the kappa receptor. I'm not going to, like I said, I'm not going to get into the science behind this. I have the full link of the full research article at a QR code at the end of this. It explains a lot of some things that we were seeing, though, and that's why I decided to include it. When you hit someone with naloxone, it does trigger a response for xylazine as well. And I thought I was going crazy because I've given many people like naloxone in the past, but all of a sudden things change when I hit someone that was overdosing, or we come to someone unconscious and or not breathing, unresponsive. They would wake up with a new panic to their face, something I'd never seen before. And this research article kind of hits it a little bit. The kappa receptor, there's three main opioid receptors in the brain. The mu receptor, mu, is the one that really acts that all the good drugs are part of. Like fentanyl is it means it only binds to the mu receptor. Morphine, mu receptor. Some of the other ones are partial mu, partial other ones. Kappa has as far as what I'm understanding, the kappa receptor has more to do with sensory motor and some of the nerve kind of things. So that's why you're not seeing people get like opioid sedated. With xylazine, you're seeing a different type of sedation. It makes sense. But next, please. So it's unscheduled in most states. You guys did a really good job in West Virginia of moving rapidly to get xylazine scheduled. In the process, there was a little bit of fallout, from what I understand, with the test strips were illegal for a brief moment until your legislature did come back into session and put it together. But most states it's still unscheduled. Federally, it's an unscheduled drug. There's talk of scheduling it, and that will just make it more complicated. I'm against scheduling this drug. It's going to raise the price for just the handling price for veterinarians, and they still use widely in animal care. My wife works with animals every day, and they sedate bunnies and kittens with it. Large animals as well, so it's safe, but it's not safe for humans. They found it to be very unstable inside of people. The same dose could elicit two completely different responses in human beings, and we'll get into a little bit of some of those responses later. But there's only, to my knowledge, 3 or 4 different references in animal care. I put my wife on this deep dive for me. That's what you get for working in veterinary medicine for 20 years. She found one about not using it in horses with lame front hooves because wounds could appear. And there's some information in another medical text about not using on cows with an inflammatory process that's happening. That's it. So it really doesn't cause wounds in animals except for very specific situations. And I venture at this moment, when I started working for Hopkins, my boss kind of melted my entire brain by telling me we don't know that xylazine even causes wounds. And I went to argue with her because my experience proved different. But in a research world, it's true. And that statement is why we're having issues in emergency rooms. That statement is why we're having issues with billing, because doctors can't bill for treating xylazine wounds. They have to, soft tissue infection, which actually is not an infection. There's a lot of issues with the fact that we don't know why it causes wounds or if it does. There's research currently going on that I'm aware of in Utah where they're using molecular wizardry and recreating soft tissue with stem cells and then injecting it with xylazine to see what happens. But anyway, I'm not a researcher in that sense. I'm a like a social science, public health in that realm. So that one's way out of my scope. And we do know it's addictive with known withdrawal issues. We do know that there is an addictive quality to xylazine. It may actually have to do with that kappa receptor stuff I talked about a second ago, but we do know that there is a withdrawal, and it's almost a syndrome. It's not always the same for each person. There's different levels. Different people experience it differently, but it's definitely, it's a song that, like someone used this example before and I love it. We all know how songs go. They have a beginning, middle, and end, but we don't know how long they are if we've never heard it before. And each person's withdrawal from xylazine seems to be a song. There are very similarities in the beginning, middle, and end, but some of these can go on for a month, month and a half. Other ones can be a week. Other ones seem to be coupled with opioid withdrawal. So that is something we're unsure of. Next, please. Everybody, so a lot of this, like I said, I'm telling a story, and the next question after I figured out what xylazine was, everyone asked why, and the answer is it's right in front of us. Pills disappeared. When pills disappeared, longer acting opioids disappeared, and then all of a sudden, a really cheaply made, easy to produce in a clandestine lab, much easier than methamphetamine. You don't need to be a chemist to make it. Fentanyl stepped on board. Fentanyl is a potent analgesic. It is an amazing opioid used gallonfuls daily in hospitals globally, for procedures and everything else. What it doesn't do is doesn't produce a good high. The high is rapid. It's real heady. It's from the shoulders up by explanation of participants. It's not the full body high that heroin used to give or other opioids for that matter. And I'm suspect to believe it's because it only acts on one of the opioid receptors. But it's like a roller coaster with only one drop, no loops. You get high, you go up, you go down, you're back to normal. So it almost has like a crack-like effect where it keeps you coming back for more. There is some tolerance or buildup, but it's not as like you would see with other drugs. So what happened was xylazine got added to the drug supply, and I'm using a Philly term, but it gave it legs. It extended the high of the fentanyl, from the 15 minutes to an hour on fentanyl to a couple hours with xylazine. Next, please. So in early 2000s, a public health scientist researcher really identified this as an emerging threat, and it was in Puerto Rico. They've slightly connected this to the horse industry in Puerto Rico, but you could buy your drugs in Puerto Rico at that time. You buy them in bundles of 3, anesthetic, opioid, and stimulant. So you were getting your xylazine, fentanyl, or xylazine, heroin, and cocaine. And it's like a choose your own adventure. You could pick what you did. You could pick where you went with your day. If you wanted to be up and slightly anesthetized, your coke and xylazine. If you want to be out for the day, it's your heroin and xylazine. But what this guy saw was wounds were appearing, and they didn't really make sense. They weren't like your typical abscesses. So he wrote a white paper. It's out there, widely available. The states got it, and we're like, whatever. We don't. It wasn't even a blip on the radar. And that's kind of alarming. Partly My feeling, and this is a Jason thought, is that the health department down there didn't really mount a battle against it. From what I gather from participants that I've spoken to in Puerto Rico that actually had early wounds, the health department would give them supplies and not really address it as a drug issue. Um, I later did a little deeper dive. The health department in Puerto Rico is poorly funded. It's not like a state in the U.S. that gets all of the funding from federal programs. There is federal money, but it's not the way it's handled here. So they're kind of woefully unprepared for the what was happening. So I think they were just in damage control and not they didn't have enough time to alert the rest of the world that something crazy is happening. Next, please. So as I said earlier, the ramp up it comes after the fentanyl thing. So 30 to 45 minutes for full onset. I've heard different times. This is from my experiences discussing this with participants. If it's from research, I'll definitely tell you guys. But everybody says the same thing. The ramp up to xylazine is when the fentanyl is kind of coming down. This number I've shortened. 2 to 5 hours is what commonly reported. The team that I was working with, participant wise, they were saying it was more around the 6 to 8 hours, but I trimmed it back based on conversations I've had now being here in Baltimore. Consensus is somewhere between the 5-ish hours. So people get high, they fall asleep. That's the telltale mark of xylazine, because opioids don't make you go to sleep. They nod you out, but you're still kind of mentally awake. You might not be cognitively, prepared to, do a math quiz, but you're definitely not sleeping. And that's kind of what xylazine does. It prepares you for surgery. And that 5 hours is you wake up, you boost, you hustle, you do whatever, sex work, get your money, get your drugs, inject, fall asleep, wake up, 6, 7 hours later, lather, rinse, repeat. And this is a cycle that goes on a couple times a day. When I first went into the rural community, people were up and walking. It was, people staggering along the sides of the street, people trying to get to their encampments. They were up though. Some people, opioids will give them a little bit of energy, and you could see it. They were, kind of staggering around. You could tell people were high. Once xylazine took over in 2020 as the predominant adulterant, you would have to go to people's homes. And that's where that woman, my Joan of Arc, came into be, because she knew where people basically, accumulated for safety reasons, and we would go there to do wound care. So the community kind of changes when xylazine happens. The wounds occur, people start becoming shut-ins because they're embarrassed. They don't want to let people know. You start seeing a lot more long sleeves covering up these, terrible, terrible wounds. And it's that community that you guys really need to reach out to most, and to decrease the stigma and the fear from medical providers and such. Next, please. So these are the symptoms that, and also this has also been communicated with. This one's been cross-checked through the science portion, but this is what people told me. When they get on, they get a rush. That rush is actually an increase in blood pressure caused by the immediate action of xylazine on the smooth muscle. 10 minutes later, you drop your blood pressure below baseline. So again, it was originally developed to keep blood pressure low. And this is where the wildly unstable part comes in. Not everybody feels a rush from it. The majority of people can tell you there's xylazine in their drugs once they know what they're looking for. Chronic use creates an amnesia-like effect where you lose blocks of time, not like with people that are addicted to benzos where their memories are kind of jumbled up. They're just out. They don't know what happened, like an anesthetic. Sedation, if you don't get to the level of deep anesthesia, it's sleepiness, but it's sleepiness like you've never seen. It's Weekend at Bernie's sleepiness, if people are old enough to have seen that movie. You're a rag doll. It's basically rag doll sedation. They're completely unarousable. Wounds are another side effect. Respiration issues is something, it can decrease respiratory rate, but the reason why it's used a lot in animal care is because it doesn't really have a broad effect on the respiratory drive. This is one of those things that I think we're going to get research in the future. I hate knowing about research because I'm a horrible researcher. So I tell everybody, I don't know you guys, but I feel like we're friends already, and I would tell you everything. Just keep an eye out. The respiration thing is something that's being looked at by another team in New York. There's definitely airway compromise though, and that comes from the next part, the changes in posture. So when people fall asleep, they don't fall asleep like we would cozy up in a bed with a blanket and a soft pillow. They just fall asleep sitting. The gentleman that is looking at the board that says a triple amputee now, he actually has a curved spine from Xylazine. He would pass out, head slumped forward for hours at a time, 5, 6, 7 hours. Um, and eventually his spine just got, when your mom says sit up straight, he's the example of what happens when you don't. Um, when I would have him stand up against the wall, he couldn't put his head up against the wall. That's how far forward. And the other thing, I put this at the top and the bottom for a reason. I want to really sandwich all the rest in the middle with these two really important parts. It decreases your heart rate. So, normally, a healthy individual, what happens when your heart starts slowing down is your blood pressure goes up. It's your body's way of counteracting a low pressure in your body. So when your blood pressure goes up, it squeezes down and your veins get tinier, they get smaller. What happens is blood pressure rises because creating pressure. When you have a decrease in blood pressure and a decrease in heart rate, that also is synergistic with the same things when it comes to opioids and a very potent opioid, we have a really big problem with overdoses. There's a lot of debate right now in a couple of the big groups I'm part of online. There is research currently going on showing that there may be some cardioprotective mechanism of xylazine. I personally, Jason, has recognized in the communities I've served, once xylazine gets a foothold of about 60 to 70%, in the samples tested, there's a decrease in fatal overdoses. It happened in the rural county, and it just happened in Baltimore. And those numbers match up. If anyone's researching, there's one for you that no one's grabbed on my end. And everybody in the community feels like it's their job is, I've given out more naloxone this year, so we are the ones that saved it. And I will definitely not tell them they're wrong, but as a nurse that's looking at things both clinically and through the public health lens, I feel that there might be a part of that. You might get too high before you get enough fentanyl to overdose, or there might be something going on with the fact it was a blood pressure medicine. There might be something happening, but people are seeing a decrease in like the cardiac arrest from overdose. Again, another question that is being researched on the East Coast and West Coast. Next, please. So again, I'm only going to touch on the overdose complications because this is really about like more of a foundational stuff. Next, go ahead. So we always use naloxone. I'm a nurse. I use the drug name, not the brand name. Narcan is really just describing the nasal infuser. The drug is naloxone. Always use naloxone. It reverses opioid overdoses. Next, please. And on all the boxes that we've been giving out, it's one specific manufacturer. They have the instructions on this little flip in the front. And the questions always when you do the training are they breathing and are they responsive? If you answer no to this, you can give them naloxone. So what xylazine does, it actually removes the responsive part. So it gives us one question. And that's when we have one question to answer, it seems like it's simple, but it's much more complicated. So are they breathing? That can be shallow breathing, that can be not breathing. And we said xylazine may slow things down, and we're not real sure about the breathing portion 100%. So this is where it gets complicated. Next, please. So xylazine intoxication does not reverse with naloxone. When you guys use the QR code at the end, you'll see what happens, but it does not reverse. And this is where it gets complicated. When you find someone unresponsive that's shallow breathing or poorly breathing or has blue lips or dusky fingernails, you give them naloxone and they're not waking up. I'm old enough to work in harm reduction long enough to know that you could give naloxone and the person within like a minute was running down the highway because they had an open warrant and they heard you called 911. Those days aren't around anymore. You give them naloxone, you wait, nothing happens. Nothing happens. 2 minutes go by, you give the second dose, nothing happens. And then you see that they're breathing. At that moment, you have reversed an opioid overdose with xylazine involved. When they return to breathing, you have to ride it out with them. It's kind of like when people overdose on amphetamine. When they overamp, you got to hang out with them afterwards. And this is changing what overdose looks like. It's changing what reversals look like. The community I worked in, we all gave out CPR face shields because it changed it that much. I carried a silicone face shield that you would use. You put it on. It's got like a filter on it, biologic filter. It's changing the game. And I started carrying a pulse ox. My rural community is predominantly white, like most rural communities. The people of color kind of stick to themselves and kind of cordon off in different areas, and we didn't have really good penetration into what you would classify like quote unquote other. The Hispanic population in the county that was there were underserved completely, and the black population didn't trust anything we were doing, so that's why we didn't have really good penetration. But a pulse ox, it will help you, but we can't rely only on those numbers, especially with people of color, because there could be some misreading of the actual device on like heavily pigmented skin. That's my public service message. Next, please. So the sedative effects from xylazine can last hours. They really do work in synergy. It's like the chocolate and peanut butter effect at Reese Cup. They're great. Chocolate and peanut butter are great individually, but they're phenomenal when they're mixed. It's the same thing with fentanyl and xylazine. Sedation lasts hours, and the person doesn't wake up anymore. The back to breathing is what you get. So now we have to start thinking ourselves as almost like rescue breathing as part of an emergency response. It's upping the game for the respondent, someone responding to that person. It's putting a little bit more responsibility on them, and as long as you phrase it correctly, it's not a big ask. If someone's willing to give someone naloxone, chances are they're willing to breathe for them as well. They don't want them to die. And it's how you approach people to explain that to them. Next. Again, I wouldn't be a good nurse unless I push this. Rescue breathing saves lives. I've seen many people sit there and I walk in, they're like, well, I gave them 5 doses. They should be up. And their lips are blue and no one's rescue breathing. So we made it kind of mandatory in our community that if you give a dose, before you give another dose of naloxone, you got to give them 2 short breaths. And that was for our staff reporting. Again, everybody was in recovery and we had an issue with people trying to give more than they should. Because, we have boxes of naloxone. So I walked in on someone giving someone, they told me it was 11 doses. The reality when I counted it was 16. And the kid panicked. He couldn't get this gentleman out of a car. He couldn't lay him flat. The seatbelt was in the way. And all he had were boxes of naloxone. And completely panicked. Because the story behind the guy that responded, his wife and fiance both had overdosed in front of him in the past. And that trauma was just making him just pour naloxone into people. So he's no longer a frontline naloxone responder in my past organization, just due to that. It was an oversight. We didn't think about it, but the guy was blue, and they pulled him out. His new wife pulled him out of the truck and started doing CPR on him immediately, and the guy is okay. The reality was he didn't go into precipitated withdrawal because he had just got out of jail. He had kids' toys in the back because he was going over to pick up his baby mama and deliver these toys that he had just purchased. That's why we couldn't put the seat down in the truck. So everybody's story matters, and that's a little aside. Next, please. So one of the flags that we figured out when people are saying that dope is really strong, there's Narcan-resistant dope out there. We found out it's all xylazine. Maryland has a pretty robust drug checking program with the National Institute of Standards and Technology. So we can sample people's drugs, send it away with just send a swab, like a Q-tip or away in a specially marked envelope to the NIST, the National Institute, and they'll check it for us with gas chromatograph, like a DART chromatograph. In the process of that, we found out that everybody was saying this is carfentanil or this is nitazines. The reality was it was none of it. It was fentanyl and xylazine. That's all it was. Um, I'm really of the mindset that it's the percent of xylazine inside of the fentanyl that one causes wounds and two is the sedation level people get. You know, if you're getting a 20%, you know, if you're getting like 10% fentanyl, 20% xylazine, the rest filler, whatever the filler would be, you know, that 20% matters. You're getting a hefty dose of xylazine every time you inject. Next, please. This is your final warning. I start easy and it gets kind of icky. These are skin issues caused by xylazine. This is my bread and butter. I'm a wound nurse. Before I became a nurse, I wanted to do burns. I never thought in a million years I'd be sitting here talking to people in West Virginia on behalf of Marshall and the team down there about wounds, but this is kind of, I'm a pig in my own mess. So next, please. We don't know why. I'm glad you went through it quick. I covered it already. The cause of these wounds is unclear. I could talk for hours as to theories, but there is no real clear-cut pathway to the wound. There's some theories that are pretty solid, but up until now, we don't know why the wounds occur. It's only speculation. Next. And this is what we do know, though. You inject on your arm, you can get it on your leg. The woman I was wrapping the leg with, she only injects in her neck. And she would always get him on her legs, and she would get them really bad. If you don't inject in your trunk, and that just means the center of your body, not your arms, not your head, and not your legs. The trunk is the jelly bean shaped part of our body. If you're not injecting in those areas, chances are you're not going to get a wound there. If you inject in those areas, like your breast tissue, in between your ribs, there's some veins that go there. If you inject in those areas, you could get a wound at the injection site. For whatever reason, the gals that had larger breasts and saw the blue veins thought that they were hitting a vein. And for whatever reason, xylazine and breast tissue is a horrible combination, and it melts the breast tissue fairly rapidly. I met a young woman that I saw her very frequently, and she would not inject in the rest of her body. And she had large breasts, and she's like, the veins are there. I know I'm hitting it. And then all of a sudden she started getting wounds, and the wounds progressed almost at twice the speed of regular wounds. And I'm not sure if she was honest about the volume of fentanyl she was injecting, if she was really hitting that vein and just injecting into the fat tissue. I was never there when she injected. She was one of the never events in my mind. I wish I could have stopped this. She swore she could get breast implants, but you need tissue to implant under. She has no breast anymore. They're all kind of rotted off. And she's kind of stuck in this weird place of massive surgery, but no surgeon will touch her for this until she gets off of fentanyl and xylazine. It's something I wear as a memory that I wish didn't happen. But snorting it causes issues with your nose. I personally have not had any participants snorting it that have wounds on their legs or arms. There is rumor from people I do trust that say that they do have participants, so it can cause sores. My experience is with the soft tissue inside your nose and your sinuses. And it goes with the rectal and vaginal administration. We did have a couple gals thinking they were going to shortchange the wound process and use it intravaginally or intrarectally, and it caused soft tissue issues there as well. Interestingly, though, and it makes sense biologically, ceasing, like stopping snorting and stop boofing and rectal administration or vaginal administration, they heal up pretty fast because the mucous membranes inside of those places in our body, we shed them rapidly and they kind of recycle themselves pretty quick. So healing happens pretty quick. The sinus issues are like nothing I've ever seen before. People expel large clumps of what looks to be dead tissue. It's pretty serious. I had a gal, it looked like she was just dripping white paint out of her nose. It was like this grayish white, and that comes from the drainage from dead tissue. And her sinuses took about 4 months to clear up. Like, she was the worst I'd ever seen. She was someone I suggested go to the hospital. Because I had never seen that before, and she was like snoring a lot when she slept. I was nervous about airway blockage internally. That was an outlier though. And one thing I have to really share with people, and I think this is super duper important, they don't start like that monster wound. That's why I pointed it out in the beginning. They don't start like that. They start with a very small wound that's like the size of a dime or a quarter or 50-cent piece. Um, Most of them start with a darkened area, like it would be like a one of those the infant um, birthmarks, and the name is escaping me right now, but it's very distinct. It's purplish. It's got a weird border to it, like an organized but disorganized border. It's not completely round. They may or may not have a blister, and the fluid may or may not be like pinkish red. If they do have one that's traditionally pink or purple colored fluid inside the blistered area, and the area does not hurt. I have not had a participant tell me these hurt. A lot of the data from many health departments across the country said these are extremely painful wounds. And I think that might be the author superimposing their feelings on it. I think this is one of those cases of someone running with information and not really validating it. Our participants, the reason why these wounds sneak up on them the way they do is because they don't hurt and they usually go missed. Next, please. A little bit more. These wounds are not infected initially. Whatever's happening is happening from the drug causing the tissue death. When the blister is covered, it is 100% non-infected. When the blister is removed, it's an open area with a risk for infection, much like if you pulled a blister off your hand. But the reality that I came to realize was true, you can count on probably both hands how many times people needed antibiotics to heal these wounds. And we're talking over months. If you get to these folks early with a tiny wound, keep it covered, keep it moist, simple wound care, they heal. It's when they leave them open to air and the dead tissue in the center hardens up, then you're up against a completely different type of healing process. Everything you see on the news, when you Google Xylazine wounds, the majority of those pictures are the sensational ones that the media has taken to generate more clicks or more readers. The reality is they start as tiny wounds, and a lot of them disappear as tiny wounds. And common wound care, don't air it out. It needs to be covered, keep moist. Do your best to keep it clean. Don't inject into the edges around the wounds. That's a whole thing that I didn't know people did. Once the wound starts, once you start injecting around the edges, you will continue making that wound larger. It's 100% certainty that happens every time you inject around the edges. People at that point, when they have a large wound on their hand, arms, or legs, they start not caring. And it almost becomes a self-harm situation that is out of my pay grade to understand. But people with very good veins will look me dead in the eye and say, I have no more veins. I need to inject here. And when I try to change their view, like go over here or go over there, they won't. So it's like it becomes part of their addiction. And I'm unclear as to why. And I found that working in the wild with folks, if you have a wound on your right arm, try to get them injected into the left arm. If they get wounds from non-injection sites, I still tell people to rotate their injection sites, because however your neck is connected to your leg, maybe go on the other side of your neck to see if your other leg happens, then we know we're in for some trouble. But by rotation, you let things cool down a little bit. If this is an inflammatory response, if the cause is that, which I kind of think it is, it allows the inflammation process to continue on, and healing starts with inflammation. If we maintain the inflammation inside of a wound bed, the wound will continue to grow. That's the simple wound care stuff. Next, please. Final warning. Again, start easy and ramp up. Next. So this was something added into my wound presentations about 6 months ago, and I think this is really important. We all know that if you hit an artery, you run the risk of putting clots into your fingertips and stuff, or your brain or other parts of your body. Xylazine, it's guaranteed. If you hit an artery with xylazine, the initial effect of xylazine is that rush, that vasoconstriction. If you flush an artery with xylazine, it causes it to like jiggle. It's like it rapidly constricts, and it just blows clots into these teeny tiny little micro vessels in your fingertips. So what happens is you end up with dead fingers. This gentleman was 2 days out. He injected in his wrist. You can still see the red dot where he injected. It was a miss. He hit the artery instead of the vein. That area is notorious for these mistakes. This guy was a professional. He thought he could handle this, and that's why it took a couple days. But Yeah, he lost those three fingers, one on either the thumb and the other one on next to the index finger, the middle finger, are completely gone. Next, please. So the one on the left is his back of his hand. That picture was taken before I realized I had a piece of white paper, so you really can't see the changes in color. It's very swollen. The center is white, and the knuckles are red, and around the center is kind of red. Um, he didn't open up. When you see this on typical xylazine wounds, those areas open up as a wound. For whatever reason, they didn't, and that's a standout. That's why I always include this. The gal on the right, this picture's in here for a reason. When I first took it, I thought, when I look back at it, I was like, my big fat head's in the way of the light, but it's not. The reality is she lost those three fingers. But if you actually take your focus off of that and look down to the left, she also lost her right foot for the exact same reason. She did this, like her hand, she came to me the day she did it. It was like an hour and a half after she injected, because she knew something was wrong and didn't want to lose her foot. I met her like 2 weeks after she injected an artery in her foot, and the whole bottom of her foot was dead and soupy and in probably the worst shape of a human I had seen. She ended up going to a hand specialist in Baltimore, like a hand hospital, and they were able to salvage more of her fingers than if you went to a community hospital. And it's a process to save them, but there's, unless you can get them to there within the hour, you really can't save it, and it's kind of moving mountains to save those fingers. Next, please. So, typical progression of these wounds I kind of covered already, but I'll go through it again. You inject, a blister may or may not form, and that's where your sore is. When you open it, the area underneath is purple. It looks like grape jelly, and I have an example. That is dead tissue. The purple inside the blister is dead tissue. The other type of wound that appears is, it's like a white center, like a completely white, snow white center with a red ring around the outside of that. That is also dead tissue. That tissue is what we would assume all xylazine wounds should start like, because we know it constricts the vessel, so it stops blood flow from an area. That's what they should look like. The fact that they look like the other one with dead tissue immediately is kind of an enigma. If you remove the blister and you do not keep it covered, they turn into a really hard piece of tissue, and I have an example. Interestingly, though, most times people like, it's a scab. It's really not a scab. It's your dead meat. But it's flush with the skin around it, and this is one of the more unique situations. Even burn wounds don't look like this when they harden up. The connectedness around the edges is fairly unique to xylazine in my experience. When it gets to that point, I have a picture of someone that had it for 7 months, and it gave them zero problems. The only reason he got it treated is he went into a detox, and a doctor there was working with me to do wound care, and we healed him up in about little less than 2 months. But he had it for 7 months, and he didn't care about it whatsoever. Next, please. So initial presentations. I have shared this photo with other presenters in other parts of the country, just so they could have this. Most people aren't documenting this. These are all the different types of xylazine presentations from an initial viewpoint. You could tell she's already keeping some covered on the left. These are 4 different people as well. The red splotch that looks like a birthmark. The next one from the left, the second one there, is the white center. That kind of purple thing in the middle is the detached skin. That's a blister. But you see the white area. If we removed the skin above that, it would be snow white and hardened, leathery, and dead. And then the red ring around that. The next one is the purple blister. It's completely covered. I'm sorry, wrong part. And the following photo there is the 2 white centers with the red rings around them. They're easily missed. This is how they start. This is what xylazine looks like when it causes a wound initially. Next. I include this photo because this is a testament to the stupidity of men. Guys thought they were going to get away from getting wounds by injecting into the muscle. Little did they know that this happened for about a month. A group of guys that were in the community were like, we're not going to get these wounds. We're not injecting in the veins. We're just going to IM it. What happens is they end up with deep tissue injuries that are just like pressure ulcers. The tissue inside the body dies. The body doesn't like dead stuff inside of it, and eventually will work to expel it. or you end up with a bad joint where you have to go get it drained. The fluid, like the dead tissue, escapes into the joint. You might have a risk for like a septic joint. You have all these bad things. This guy injected for whatever reason into his wrist. He did not have strong muscular wrist, but he injected into the deep tissue. He needed to get this surgically evacuated. His wrist had a drain in it for a while. The local hospital, was actually putting latex tubes like you would put in a dog that were just open to air and draining into like bandages with the instructions to come see me, because of all the people that would leave with expensive products and never show back up. It's not the way to work. It's not the way that a hospital should be operating either. Next, please. This is that cherub I talked about earlier. This is her ankle. It was covered in the photo. She picked it right before we took the picture. I asked her not to. That's what that little black hole is. This was a perfectly ping-pongish, half of a ping-pong size fluid blister that really showed what the Xylazine blister looks like. But she played with it while we were sitting there. Next, please. So the gentleman on the left is the one I talked about. He had that for 7 months. The redness around it is not infection. The body is trying to push that out. It knows it doesn't belong there. It's trying to expel it. But because it's attached at, I don't know, probably about half of that is still attached at the edges, it can't expel it. On the left side of that photo, you see that there's like yellow tissue. That's meat. That's the tissue healing in around it. That side had detached over time, and that would heal before the other one. We softened that up with Vaseline and keeping it covered, taught him how to take care of it. We really softened that tissue. He was the only person that I debrided in any of these photos. He was the only person I cut tissue out of because we were trying to expedite it. And since it had been there for so long, it had grown inside, not out, because it was attached at all the edges. As the body would kind of have a little bit of drainage, it basically created like a cone-shaped wound. So 7-month-old wounds are deeper than they look. If we had treated him initially, they would probably be about the depth of 2 quarters, very shallow, and keeping it covered, keeping it moist would have healed it. But 7 months later, it ended up with 2 big craters, and he healed up beautifully too once we got it going. On the right-hand side, that's a fairly new wound. He kept it open. It dried out a little bit. But I use this photo because it's a really good show of, if you look at 10 or 11 o'clock on that photo, you see purple. His wound was not done evolving. When there's purple like that, it's dead tissue, and the wound is as big as the purple edge underneath the healthy skin. So all of that will eventually open up, and did eventually open up. He went from having something the size of, say, I don't know, like 2 inches by 1 inch, to having something like almost completely round, 4-inch round wound on the bottom of his hand, or the bottom of his wrist. Next, please. So this is what happens when you keep them covered and moist. The grape jelly is on the left. That's his finger. He was not a rookie to wounds. He knew what Xylazine wounds were. He was getting ready to go into detox, and he thought he would get away with not causing wounds by injecting into the veins in his finger. Which, I mean, he's getting ready to go to detox. He was panicking. None of that makes sense. But this is what he ended up with. This happened the night before, and he knew to remove the skin to start the healing process faster, because detox facilities won't take you if you have open wounds. And he knew that he had a small window of opportunity mentally for himself to get himself into detox. On the other side, though, this was a white wound, the white center with the red ring. This we kept covered and moist. It's too moist. The wife was addicted to benzos. I have a picture of her feet as well in this photo, in this presentation, but she was addicted to benzos and would wake up from a high and just change his dressing. So in a perfect world, the white ring around the edge wouldn't be there. We wouldn't keep it that moist. But the wife was performing amazing wound care, especially with her pharmacological deficit. And I never stopped her. He healed up beautifully. I'm nervous when people use their fingers and their feet, because if it's so close to bone, the risk for infection is so high, and the risk for amputation in a hospital that's not comfortable, like letting things ride. A doctor would sooner cut that off than go through the process, because of the trustworthiness of the patient. The risk for the patient's much higher. I have a low tolerance for shenanigans, but patients appreciated the fact that I would come to them, and they had beautiful compliance. I think inside that statement is some truth of what's wrong with medicine today. Next, please. These are your infected ones. These are pretty much the worst ones are going to be in this picture. Gentleman on the left, I was called in. His girlfriend called me in. Interestingly enough, we created a new rule that the person has to ask for me to come in. So it became our vampire rule. I have to be invited into your house, tent, hotel room, motel room, or living arrangement. And we deemed it the vampire rule. If I couldn't talk to the person or my peer couldn't talk to that person, we weren't coming. It stops situations like this. I walked in, smelled immediate infection in the room, but the guy was completely 100. I could have taken his kidneys and left a $10 bill in his belly. He wouldn't even known it. So he's prone to Xylazine wounds. His foot was wildly infected. I did convince him to go to the hospital. We could not salvage that. It was infected. He had early signs of cellulitis and sepsis. So they amputated the toe, and he has the rest of his feet. And the guy on the other side, he went to the doctors. They told him he needs an amputation. He is covered head to toe in tattoos, and he is the scariest human being that I had contact with. He was a diesel mechanic and a really good one, and he still worked through his addiction. And the wound happened because he got a wound on his finger from an injection site and kept it covered with mechanics gloves. There's really thick non-latex gloves. But instead of getting new ones, he would use the same pair over and over, and eventually it got infected from keeping it wet, moist, and like filthy. He didn't want to go for the amputation. His joint was locked when I met him. This is the day I met him. Again, I was terrified. We actually healed his finger. His joint is locked, and it's because the tendon is tight. He could get it. He'd have to go to surgery, and they would release the tendon, and he would have most use of his finger, but we healed it. So he did not need an amputation. He's still a mechanic and a really good one, and not as scary as he looked. Next, please. And this is the gal I talked about that was on benzos that would take care of her husband's foot. This is my Rosetta Stone of Xylazine. After looking at this photo, I realized I had a gold mine and asked to come back in a week. And what I ended up with was day one, all of those wounds starting from her big toe back, except for the goldenrod colored one, the mac and cheese colored arrow. All of those are injection site wounds. I sat and watched her do it. Her wounds appeared almost instantly, not quite like this, but they were already demarcated. They were already in her foot at time of injection. So I asked her if I could come back, take a picture. And when I did, I saw what early Xylazine looks like, and she's the first one I saw the two different types of wounds. Interestingly, though, the mac and cheese color one is pointing to a non-injection site wound. If you zoomed in, there's a mosquito right above it too, which is ironic. So I saw the moment she got a mosquito bite too. 5 days later, we returned, and she didn't do anything to them. And this is what they look like 5 days after that. And she's got new ones. It's obvious her foot's slightly swollen from inflammatory process, and there's new wounds on board. Excuse me. And you can see the non-injection site wound with the dead tissue. They all look identical. They all healed up pretty much the same. Next. Smartly, I did remember to return to get a healed photo. Her foot's wildly swollen from other wounds up her leg. But this is what it looks like when you don't take care of the wounds and you're doing the most minimal amount of work. At this point, the guy whose foot she saved was no longer with him. They were not married any longer. And she had a new boyfriend who did not touch her wounds or help her with anything. So this was a benzo in and out kind of thing. And sadly, she passed away from fake pressed benzos that she was buying from a veteran. He had Xanax bars, and the VA stopped giving them to him. And he was just selling them. And he went to the secondary market to buy them. And what he ended up buying was like a designer benzo, like one of the new synthetic benzos, one of the different ones, and a mega dose of xylazine. And she injected it and never woke back up. Next, please. So the treatment concerns and stuff that we really want to talk about, and I've hinted on them, you can't place people, at least in Maryland, into detox or treatment with wounds. The hospitals don't really know much about it. When they go to get cleared in the hospital for detox, hospitals see red and immediately think you need a surgical consult. Surgeons don't know what they're looking at and immediately think you got an infected wound that needs to be removed. The reality is this is a learning process. Health departments or public health and like syringe programs and street level programs figured out how to treat this out of necessity. And this is in my lifetime the first time the community figured something out before the hospitals did and providers. Since there's no research on this and there's people are clamoring for it, hence why I'm at Bloomberg, we have a deficit of the research to back up what the hospital can do legally and can't do. So we're working on it. But hospitals will amputate sooner than go through the process of healing a wound over a couple months. So our folks that were being treated with like methadone or buprenorphine, the providers aren't treating xylazine withdrawal. So you could be in detox and you're not getting xylazine coverage, and people are leaving at that like 3 to 5 day mark exponentially. And this comes across for like outpatient, like methadone programs where like our people aren't showing up anymore. They're saying we're not listening to them. We're going up as fast as we can. A lot of times off-label increases with providers that were comfortable doing that, and it still wasn't touching the withdrawal. And it was somewhere between like the 3 to 5 day or like the month mark. In hospitals, you can get full compliance out of a participant with like full agonist opioids, at least in our experience, for like that first couple days, and then something turns on inside them that's pure anxiety. Once they experience a xylazine withdrawal on top of an opioid withdrawal, people are terrified of getting treatment. It's if you think opioids bad, it's like adding, just like the peanut butter and chocolate concept, is two of the worst things that should ever put together. And then drug consumer knowledge. There's a train going by. I apologize. Drug consumer knowledge is really relating to the dealer and the purchaser, because ultimately the low-level dealers are just consumers in their own world as well. They're not the ones importing. They're being told they have something in their possession, and they don't know what they have. The dealer can swear by their supply, and they don't know what it is. That's why one of the programs I'm working with, and I'll touch on it, I'll briefly touch on it, is doing mobile drug checking with a technician, the whole 9 yards, with an FTIR, with a machine that can give you a pretty accurate reading, for the most part, of what's in your drug supply and not destroy your samples. Next, please. So withdrawal symptoms, I said before, are kind of a poorly defined syndrome. We know this is all from patients. We know there's extreme anxiety dysphoria. The blood pressure part was reported by the young man that's the triple amputee now. It sends you to the emergency room. You come in with like rebound hypertension, and it's a hypertensive crisis. So you win your trip to the ICU, and they put you on special medicines IV that drop your blood pressure, nitroglycerin, and his blood pressure, he was describing like how some people describe before an aneurysm or right when a blood vessel bursts. So this gentleman was experiencing like 240s over 120s, 130s. So the pressure in his body, like he was gonna, if he had a bad vessel in his brain or body, it would have burst. He just collapsed. He said he heard loud screaming, and his vision went blurry. He heard this weird, loud, rushing, screaming sound in his ears, and he woke up in the ICU. The withdrawal goes back to the drugs, the tricyclic antidepressants and the phenothiazines. Patients are reporting psychiatric symptoms, head zaps, like I feel like electricity in my brain, feeling that someone's touching their skin or their hair or rubbing fingertips down their backs, and a feeling that they have like pure, like it's not. There's one type of drug that gives you the effect of, I got to keep moving. It's a weird movement disorder. This is something that's like that on a scale of like 1,000. The best person to ever describe it, the best way mentally I image it, that they said was, it feels like there's 1,000 Super Balls being launched at top speeds inside my body, pulling me in different directions. And when I get there, I'm not content. I need to go in another direction. And that's an inside feeling. It's people sometimes act on it, but the majority of folks will sit still through all of this, and it just adds to the anxiety. And most folks don't even know it's happening, so the paranoia kind of kicks in. Next. So this is where I come in. This is what's going on. Initially, research was only single case studies. Now it's increasing, but there are multiple case studies in one article. There's some great stuff coming out of Philadelphia and the team there. But noted in literature, Up-to-date literature right now: increased agitation, anxiety, shaking with chills. Interestingly, changes in heart conductivity. It does work on blood pressure, so this might have something to do with that. Or else it might be part of the cardioprotective mechanism I mentioned earlier. But some people have a weird heart conductivity, and what that means is your heartbeat. The electrical impulse is your conductivity, and then a regular one means you might have an irregular, like part of your heart may beat or flutter that isn't supposed to. Um, and they're connecting that back to xylazine. Hallucinations and dysphoria. There is some interesting cases in New Zealand of two veterinarians that were injecting it into their body alone with no other drugs, and the doctors were wise enough to document like every step of their process. The one veterinarian's cognitive ability had declined so much that he was no longer able to practice medicine, and his basic family takes care of him. Um, I do have young men in Cecil County, in the county I worked in, that did have cognitive decline over the 4-year time frame, to the point where I wasn't sure I was talking to the same person. Um, and that's all anecdotal. This person had suffered overdoses, so it could have been a anoxic brain injury causing this. But we did see a decline in just conversational ability of chronic abusers of xylazine. Next, please. So I stole this from my boss, and the next slide too. But this is what nope, go back. This is what I'm part of now. I'm sitting inside that truck, not the exact one, but one that looks just like it. And we hit up multiple locations in Baltimore City. We hit each one twice a week. It's available to anyone that steps on. The PrEP portion is for HIV prevention, for people that inject drugs, and we hit a couple hiccups with some computer stuff. Integrating Epic into a mobile vehicle was complicated in the way that we needed it, but we're putting our Epic team through the ringer. That's the only part of this that requires computer medical access. We're doing drug checking, harm reduction services, and clinical services, connecting people to what they need. Basically, like outreach program on wheels, but we're teaming up with like syringe service providers, SSPs in the community. So we're sitting in front of one in Baltimore City currently, and I go in and introduce myself to the team, start to meet everybody, get to know the ones that are really in the game for the right reasons, and have them suggest folks come out to see me. And this is how I get myself into the community. It's different to integrate yourself into a predominantly Black community. Again, like I said in the beginning, they're guarded. But having your local champions vouch for you, it takes a lot to get to that point, but it's well worth the effort. Next, please.
Sorry, we're stuck on this slide. Let me just see if I can get it to advance. My apologies.
It's okay. We're towards the end anyway. The next slide was
There we go.
preemptively. This is the team. It's myself, obviously. The gal next to the sign is also, she is our drug checking technician, and that's our medical assistant. She's the jack of all trades on the truck. She's helping out with participants that come on that need help with insurance issues, connecting people to insurance, maybe other resources in the community that's not well defined in our grant. This is one of the more interesting projects I've ever been part of, because it's teaming together. I don't know of anyone in the tri-state area that does what she does. And interestingly, she's from West Virginia too. But I don't know anyone in the tri-state area that does the drug checking. And the person that put together this research project is putting together a pretty neat team of people that are with unique talents. Next, please. And this is it. This is research. This is me blowing the tooting a horn, but you got to research it. It's a public health issue, not a legal issue. We need to get it away from the legal terms. We need to get it away from Congress and all that other stuff. This is something we need to get our hands on and get the health industry and the health world on board with the public health side of this and work through it. We all need to come together and share. I really thought research was going to be these isolated things, but people that are in research, whose hearts are in it for the right reasons. We share all of our information. And through this process, we can take evidence-based solutions and adapt them to what works. If we're using law and the other side of the concept here, we're not going to use health person-centered approach to this. We're going to use the legal approach, and that hasn't worked. You can't lock people up for having wounds. Prison systems don't like it. We ran into this before where people would let them be out until their wound healed, then take them in for their trial dates and stuff. It's crazy. Next, please. This is my contact information, and the last slide, you can go to the last one. This is the QR code for the article about xylazine being an opioid. I put this on here only because this is actually a big deal for a lot of folks, and I don't know enough about the science to even speak to it in the breadth it deserves. But that's that. Hopefully, I kept it within the time.
Yes, excellent information, Jason. And want to make sure we have enough time for our next presenter. But we did have one great question come in. If you would have time to address it. This person asks, have you had any experience with this drug in pregnant women? Also, neonatal abstinence syndrome symptoms for babies that were exposed.
So, I've been with the research portion. Like my career changed about a year ago, give or take a couple days now. I was working with a doctor in that small community hospital. She was seeing things with the pregnant mommies that had drug issues, and it was different than her typical like substance exposed babies. We did not expand it beyond that because I did not have, HIPAA clearance for the hospital. I didn't go through all that process, so she couldn't share a ton of stuff. But we were working towards trying to understand what's happening to the baby. There is definitely something like I said, she was out of my pay grade because she caught it. She was part of medicine that was aware that something was different and wanted to do something about it. But I know there's the next speaker will probably be much better to speak to that context. The woman that I worked with, that picture of her in the butterfly wings, she had a child she had two boys. One was exposed to methamphetamines, the other one's exposed to fentanyl with xylazine. So those two boys are completely different. I'm going to their fifth birthday soon. They're kind of Irish twins, and personality-wise, developmentally, they're on track. The one with the xylazine exposure is slightly delayed in some of the developmental markers. He's doing well in school, but school's much more of a struggle than the other child. And that's all I can speak to it about, though. I wish I could answer it more. I'm going to hang on for the next presenter just to listen to what nobody yet is talking. I'm sure research is going on behind closed doors, but nobody's talking about it yet. And this is something that needs to get spoken to.
Excellent. Thank you so much, Jason. Excellent presentation today. I'm sure all of us learned so much from that, and it's very insightful. And thank you for hanging around for our next presenter, who is Dr. Zach Hansen, the Medical Director of Marshall Health's Division of Addiction Sciences and an assistant professor with the Joan C. Edwards School of Medicine at Marshall. He's certified by the American Board of Family Medicine and specializes in primary care and addiction medicine. He obtained his medical degree and completed his residency at Marshall and was instrumental in creating PROACT, which is the Provider Response Organization for Addiction Care and Treatment, a collaboration between several local entities that bring together behavioral, social, and medical resources from the community to provide comprehensive care for those seeking treatment for substance use disorders. With that, it's my great pleasure to turn today's presentation over to Dr. Hansen.
Hello, everybody. Great presentation. I thank you so much, Jason. About half of the things I was going to say, you've already hit, so you made my job easier. But that's great. So the first thing we'll do is sort of address that question. We've seen probably, I think, 8 babies in the last few months with xylazine exposure. We are able to test for xylazine in the core toxicology that we're doing here at Cabell. And so there should be a paper coming out. It's been written, it's been submitted. I just don't know when it'll necessarily get accepted. And so that will be coming out eventually. But definitely seeing some sleep issues with these infants, which is to be expected, I'm assuming. Seeing some labile blood pressure and heart rate, again, which you would expect. I will tell you, from a treatment standpoint, we have not had much success with any of our traditional meds. Using clonidine has not been as helpful as it sometimes is for opiate exposure. The scores are tending to stay high. They're very uncomfortable. They're very restless and very difficult to console. And so now that we've begun to identify, hopefully we'll start to get a more clear idea of what the sort of typical presentation will look like. And then we'll have to start figuring out what we can do from a treatment standpoint because we have not had much success up to this point other than providing therapeutic handling and then just trying to ride it out, so to speak. So if we look at sort of xylazine from a local perspective, I reached out to our toxicology lab that was able to add xylazine to our screening process or our confirmation process just to sort of get a sense of where we're at. And so they found it in about 487 specimens in the last since June of 2023. This was 351 unique patients. About 115 of those were in treatment with us here at our treatment facility of PROACT, which is out of about 942 samples that PROACT has seen or has sent. And so we're seeing in about 12% of the samples of patients that are coming through here. If you take out the 300 or so patients that are biweekly or monthly at PROACT, then you're probably looking at about a 20% positive rate for people that are early in their sort of treatment course with us, which is pretty significant. If you look at those 487 specimens, norfentanyl or fentanyl were found in every single one of those. And so we have not come across any monoxylazine sort of drug screens or exposures. And so it is at this point is only being used as an adulterant or cutting agent. And so methamphetamine was also detected in about 368 of those specimens. And so it seems that our local brand tends to mix the fentanyl, methamphetamine, and xylazine. So we're sort of getting that trifecta for a majority of those specimens. And so if you look at the fentanyl positives at PROACT, about 61% of the fentanyl positive drug screens at PROACT also included fentanyl or also included xylazine. And so a majority of the fentanyl in Huntington in our site appears to be adulterated with xylazine at this point. And so I don't have numbers for other areas of the state, but clearly in Huntington, it's definitely here and it's definitely there. And so I will make sort of two other points if I can find them. One of this, I found this very interesting. This is from a DEA report, sort of looking at cost. Xylazine costs about $6 to $20 per kilogram, where fentanyl for a kilogram is somewhere between $10,000 to $90,000. And so from a financial standpoint, and if you look at our drug dealers as capitalists, they're adding this at a much reduced cost, and then you're getting this greater effect. And I guess you could argue that if they're only using a few times a day versus multiple times a day, maybe that'll hurt their business. But I don't think it's hurting their pocket too much because it's keeping them coming back because more and more are doing it. Thus, we're seeing it more and more. And then I missed the first part of the talk, but looking at sort of at a study that came out of Maryland in 21 and 22, and they found xylazine in about 80% of the drug samples that were containing opiates. And so it appears that Huntington in particular is sort of moving towards sort of where Maryland was a few years prior, which is very scary. As far as from a treatment standpoint, we have not had any significant success with identifying those patients that are having significant withdrawal from the xylazine and sort of addressing those. And so we're still kind of using sort of the standard of care of buprenorphine products, and then doing as much therapy as possible to try to help support them through sort of any withdrawal that they're having. And that's the information, I guess, that I have that hasn't already been presented. So I will open it up for questions if that's the plan.
Sure, that sounds great, Dr. Hansen. I had one request just come in chat, was wanting to see Jason's contact information. Again, this individual said she grew up in Cecil County, Maryland. She lives close by and she'd like to help her community any way she could. So if you don't mind, Jason, I'll put the information up here. So you can get in touch. All right. Let's see. I was looking at other questions that we have had that have come in for both of our wonderful presenters today. Let's see what we have here. This question asks, can you, this would probably be for Jason, can you share supplies that are critical to keep on hand while conducting outreach work for treating individuals from xylazine?
So it was cool. I got hired on with carte blanche on a big grant to order any supplies I wanted when I worked at the nonprofit and working in a wound center. I was like, I want all this stuff. The reality is I actually fell back into old traditional wound healing, like Civil War level care. Keep it covered, keep it moist, and do your best to keep it clean in that order. So anything you can keep a wound covered with, the way I treated that girl's foot to actually get it to heal, I used something called Zeroform. It's almost like a flat linen type of dressing that's impregnated with Vaseline and something called bismuth. The magic is actually in the linen portion of that dressing because it's very occlusive and holds the Vaseline really close to those wounds. But your common wound care supplies, keep it covered, keep it moist. Vaseline, your like a product like your Neosporin or bacitracin. It's not really much the antibiotic portion of that works. It's the carrier that carries it, the emollient base. Usually it's an oil base or something similar to an oil base that keeps the tissue moist. As a caveat to all of this, I have to say that older folks sometimes can become allergic to bacitracin and Neosporin, your polysporins, and you do end up with a dermatitis. So I have a tendency not to use that. Something to keep it covered in moist, Vaseline and gauze and a pad behind it. Just keeping that mindset. I hate to give specific recommendations. I use Zeroform ABD pad and Coban, which is the self-adhering gauze. That's what I use for 90% of everything I treat, except for abscesses. But as long as your mindset is keep it covered and keep it moist, you're safer. And then, like that's I guess the answer you guys are looking for. And I do want to add, I was in Huntington to do something at Marshall a while ago, and a gentleman was walking through the street, and it just so happened that he looked like he was overamped on meth, but he had a xylazine wound on his wrist, and he couldn't control his body. He came over and he walked past me and bumped up my car. He's like, "I'm so sorry. I'm not trying to steal anything." Like he was terrified that he hit my car with his body, and I could care less. I was getting my bags out of my trunk. I was like, "You know," I'm like, "Do you know you got a wound on your arm?" He's like, "No." I was like, "Well, it's your lucky day." So I gave him a bag of supplies, and it was literally a Vaseline packet and Band-Aids. He had a tiny xylazine wound on his wrist. I was like, "You're probably not going to remember this. You're going to find this bag, and here's a tiny little bit of instructions. Keep it covered, keep it moist. Don't let it air out." So yeah, just to speak to it's in your community.
Thank Thank you, Jason. Another question, which Dr. Hansen answered in Q&A, but for our recording and any folks that might be listening, this person asked, are we seeing multiple wounds in the Huntington area due to added xylazine? And if you wouldn't care, Dr. Hansen, to repeat your message for folks who may just be tuned into the audio. Oh, and I believe you're muted. Sorry.
Yeah, we have colleagues, sort of partners working, primarily in the homeless sort of population, and they definitely have seen xylazine wounds and are treating those. I do not know of any xylazine wounds that have sort of presented or that we've seen here at our treatment facility, which I think is a little bit odd. I would assume that we would find them. I'm hoping patients aren't covering them up and we're missing them. But it seems to be more in sort of the homeless or unsheltered population at this point, from what I can tell.
Thank you, Dr. Hansen. Another person asks for either of you, have you ever tried Unaboot material? If I'm pronouncing that incorrectly, forgive me. UNNABOOT.
I'll take it, Doc, if you don't mind. I have, and it's kind of an off-label use. So the moisture that product contains, there's two different types. There's the calamine base, so it's the pink one that hardens up a little bit harder. Then there's one that's a zinc paste one, like the zinc paste boot's slightly different than the original Unaboot. I have used that before, completely off-label, roguish, for someone that had a lot of arm wounds that I wanted to keep that dressing on and leave it on, but I used it bare skin. I didn't put anything underneath of it, nothing absorptive. I literally just wrapped it. This is the first time in the past 2 years of, like, nationally speaking, anyone's ever asked me that, and I'm impressed whoever asked it. You're definitely thinking in the right direction. The issue we had with it, the patient did not come back and had a hell of a time getting it off because it started to harden up like the Unaboot's supposed to. And it almost creates like a cast-like effect. And that person was really upset that it got to that point, but like, she missed following up and was nowhere to be found. So that's why I didn't use it anymore. But I do have that secret spot in my trunk with the wound care supplies I'm not supposed to have, and that's one of them. In case we ever find that again.
Okay, and we'll wrap up with a comment for you, Jason, that came from one of our attendees. This individual says, thank you for your presentation and your candidness. The fact that you've worked with and experienced rural areas is a breath of fresh air for us here in West Virginia. I learned so much today, and thank you for all you do for humans.
Thank you guys so much. That's a big compliment. I like working in a city center because it's different clientele and different folks. But I'm working with my group now to try to edge ourselves back into rural communities. There's so much funding for city centers, but there's no funding for the rural community, and they're the ones at the biggest deficit. And I'm a big flag waver when it comes to speaking to government agencies and stuff about funding your rural communities, because when they start to become unraveled, the other communities that are a little bit more densely populated, they start to see a different trade. So you have to speak the language that makes people nervous sometimes. If you fund rural community care, it contains the problems. I hate to use those terms. It's so negative viewpoint, but it's a way that, I don't know, my heart goes out to everybody that's suffering in rural communities because there's no resources. It's hours to get to a hospital. It's hours to get to people that care. So it's folks that are on here right now that are taking the biggest chunk out of that problem and working on it. So thank you for having me. I wanted to be on this because it is West Virginia. I'm starting to fall in love with the state a little bit. I've been down there 3 or 4 times now, different areas. So yeah, I see the charm. I get it.
And we would love to see you here in West Virginia. Thank you so much for your time. And thank you, Dr. Hansen, for providing the local perspective and what's being done here in the Charleston-Huntington area. Well, that will wrap up today's webinar, but stay tuned because this is not the last in our webinar series. We have another one slated for June 4th at 1 p.m. And the title of our next webinar is going to be Breaking Barriers, Empowering Recovery Through Legal Aid of West Virginia. We'll be featuring our keynote speaker, Brendan Wood. He is with Legal Aid and will be providing information that is very relevant for all of the communities that we work with. So go ahead and mark your calendar right now for June 4th at 1 p.m. We'll have registration open via all of our Healthy Connections and Quality Insights and Center of Excellence communication channels. So you will expect to see that in our social media or in our morning memo or Get Connected newsletter. If for some reason you're not signed up for that or you want more information on this upcoming webinar, or maybe have a question or comment for our two excellent keynote speakers today, you can contact Grayson Kist at gbaker@qualityinsights.org, and she can pass that along. On behalf of everyone who helped produce this webinar today, we really want to thank you for attending. This was phenomenal information, and we look forward to seeing you June 4th for our next in the series. Have a great day, and thanks so much.